Thank you for watching this program tonight with the best physicians of the region. My name is Dr. Luis Munoz, and I'm the president of the El Paso County Medical Society. It is our hope that you will find this program informative and interesting. We at the El Paso County Medical Society invest in community education with our programs. I hope you will find this program very informative, with great medical advices and great medical information. Thank you again for watching this program tonight, and have a great night.
Hi, I'm Catherine Berg, the host and the moderator for the El Paso Physician. The El Paso County Medical Society has sponsored this show now for over 26 years. We've had a lot of topics throughout those years. And kudos to the doctors on the El Paso County Medical Society, because this is the longest running local medical show in the United States, in fact, around the world. This show that is produced in El Paso gets picked up by PBS stations in other cities, which is great. We are so lucky here because we have access to local doctors. Specifically talks about treating people who are in our region. We have unique issues that are in our region, and the doctors that come here and the doctors who grow up and stay here specifically talk about that. And it's so nice to have a program that is specific to our people and our region. The El Paso Physician is a place to tune in. One of the things that the show's about is giving free advice to you, to people who have questions about what is happening in our region and how is it that so many people are leaving El Paso for medical care when there really is great medical care here. This program really helps showcase our doctors and our different medical facilities. If you've ever had a question on one of the topics that we presented, you are welcome to email the El Paso County Medical Society and its doctors, and we will make sure to get that question answered and back to you. The place to email is epmedsoc.com. That stands for El Paso Medical Society. Again, epmedsoc.com. You can email your questions there, and one of the doctors from the El Paso County Medical Society will get back to you. Through the years, 26 years, we have so many episodes that you can go back and watch. Now that streaming is in place, there are 3 places that you can do that. pbselpaso.org is one. You would have to go there and look for the logo, the El Paso Physician, and we have, again, many shows that we've aired through the years. Also, the El Paso County Medical Society.com. And then there's always the good old-fashioned YouTube. Just in the search engine, YouTube, and then type in the El Paso Physician, and you will see all the topics that are there throughout the years. If you're looking for a specific topic, just enter that into the search engine, and you'll be able to find us. Thanks again for tuning into the El Paso Physician. A colonoscopy. One of the greatest gifts that you can give to yourself to save your life. Colon cancer is one of the few cancers that's preventable. A colonoscopy, without question, can prevent colon cancer, and you may ask why. Well, it's because suspicious polyps can be removed during the procedure before they turn into cancers. During the next hour, we have physicians answering questions about prevention, diagnosis, and treatment of colon cancer. This evening's program is underwritten by Texas Tech University Health Sciences Center and also Dr. Richard McCallum. And we also want to thank the El Paso County Medical Society for bringing the show to you each and every month. Good evening, I'm Catherine Berg, and you are tuned into the El Paso Physician. Thank you for joining us. Tonight, we're going to be talking about colon cancer prevention, diagnosis, and management. With me this evening, we have 2 veterans and somebody who's brand new. So this is going to be a lot of fun. We have Dr. Sherif Elhanafi, and he is a specialist with gastroenterology. He is also an advanced endoscopist who is trained at the Mayo Clinic. And your colleagues has told me that you used to do some transplant surgeries and stuff too. And he's rolling his eyes because they're bragging on you. And you're like, no, stop.
Not anymore.
And then we have Dr. Robles over here, Dr. Alejandro Robles, who's like, I'm just a normal guy. But then Dr. Guzman's like, no, he's great. So we have a good panel tonight. Again, gastroenterology. And then Dr. Jesus Guzman, who is a gastroenterology fellow. So still somewhat in training. And if you notice his coloring today, he is Texas Tech born through and through from El Paso as well. Thank you so much for being here with us. And this is going to be a great show. So we often, prior to us airing or being on, we talk about things that we are going to discuss throughout the program. So the first thing is the colon in the digestive tract. There's all kinds of stuff. There is the small intestine, the large intestine. There's the colon, there's the rectum, there's this, that, and the other. So I would like to ask Dr. Elhanafi if you can describe to our audience of everything in the digestive tract, what does the colon do and why is it so important to have screenings?
So, thanks for having us, Catherine. So, colon is a very important part of the digestive tract. It's called the large intestine. It starts from the end of small intestine and goes till the anus and rectum. So, the role of colon is very important. The main role of colon is to absorb water, and the digestive material goes from small intestine, very liquid material, and the colon absorbs the water and to make it little bit in solid form. And other function of the colon is to absorb some electrolytes and nutrition. So this is the main two function of the colon, and it also has some microbiota which can maintain the balance of our body microbiota.
Great. Nicely explained. And as I was talking about a few moments ago, so we hear about and know about colon cancer, but we don't hear or know anything about small intestine cancer or large intestine cancer. Is that even a thing? Or why is it and how is it that colons are where the cancers grow? And Dr. Robles, I'm just going to throw that your way.
Sure.
If you'd like to take that.
No, absolutely. So there are cases of small intestinal cancers. These are rare, though, in nature. It's the colon it's a little bit more common site to get these type of cancers. It's actually the third most common site of cancer in humans. So it's something that's out there. So again, the cancers do exist in the small bowel, but it's definitely way more common in the large intestine.
Okay, Gotcha. And Dr. Guzman, I'm just going to get you into the loop here. And I'm going to start with the kind of the hard question, the controversial questions, is of screenings. So screenings change an awful lot with all kinds of oncology. And years ago, colon cancer started screenings at about 50. And I want to say last year that the recommendation went down to 45. Can you just involve our audience in what the different screenings are and have been, and why is it now 45 instead of 50?
No, definitely. So there's different screening modalities. We have different screenings, which are some are stool-based and some are direct visualization. The stool-based studies are pretty much taking a part of the stool and detecting blood. We have something called the guaiac fecal occult test. This pretty much uses a chemical staining to be able to detect blood in the stool. We have the FIT test. The FIT test is a little bit, it's better. The reason being it has a higher detection rate than the previous guaiac FOBT test. So this one in itself uses antibodies to detect blood in the stool. And then this one you do it approximately every year. Both of these are done every year to be able to detect colon cancer.
And are these done in a doctor's office?
No.
For example, the fecal occult test, how is that done? Is that something that you can mail in?
It definitely is.
Okay.
So essentially, it's something that you could do at the privacy of your own home.
Okay.
Usually, you receive a package. The directions are relatively simple. You get a package at home, and when you go to the restroom, you'll take a small little brush and insert it into the stool and put it into a little container.
Okay.
And that container you Ziploc back, and then you mail it back.
Gotcha.
Okay. And that in itself, you do it in a one-step process. And that is enough. And you do it once a year.
Okay, gotcha. And then you were talking about the FIT test after that. And if you can also describe how that's done.
So that is the FIT test. And
that is the FIT test. Okay.
The FOBT test is more of a chemical staining that you use a small sample.
That's right. You said
stool.
that. Okay.
Okay. But like I said, we're moving away from the FOBT test just because that one requires dietary restrictions. Such as not eating meat, because that can cause what we call a false positive. And then you have to do 3 in a row, actually. to be able to increase the sensitivity of this study. So we're moving away from that, and we're moving more to the FIT test. It has a better detection rate. It's still something that's done once a year, and it's something that you can do simply at home.
Okay.
And we have other studies that you can do every 3 years. It has a little bit higher sensitivity. When we say sensitivity is how good is it at detecting something. So the FIT DNA test is something that it uses other components. It's still the antibody test, but now it's looking for altered DNA, things that we can see in cancers, different mutations. So this one is also really good in itself, but so that's why you can spread out the screening interval to about every 3 years.
Okay.
And now we move on to the ones that we as gastroenterologists prefer.
Exactly. And so I do want to very much talk about the gold standards
Yes.
that are being done. So these tests are for people who, for whatever reason, have reservations. And we're trying to teach people, let's not have reservations, because this is, again, colonoscopies can prevent cancers because they take a polyp before anything can start. So would you like to continue, or do you need a break and let Dr. Robles talk, or go? He's got his notes and everything. I love this kid.
Yeah,
He's on it. He's on it.
It's like I've got my notes, you've got your notes.
It's actually something very important, just because. So one thing that I really want to emphasize is that
Right.
the FIT test, the DNA FIT test, all these are screening. If there is a positive value in any of these, that still needs a colonoscopy.
Bingo. Yes.
So it serves no purpose if you do the test and it's positive and don't get anything after it. Because the whole point is to be able to detect cancer early and be able to, if it's something that's a large polyp that we can remove, treat it. If it's an early cancer, detect it early.
Okay.
And this is why we prefer a colonoscopy.
Of course. Perfect.
That's to us, it's the gold standard. It's because in this, it's a very low risk procedure. It doesn't have many complications, and by doing so, we can actually detect cancer early, or detect precancerous growths early, polyps,
Right.
and we can remove them.
Right.
And by removing them, that essentially we remove that risk, and that's why these, if you get it one done and you have nothing there, then you can screen every 10 years.
Beautiful.
Now, depending on the amount of polyps we see, then the screening interval changes. But it's all dependent on what we find. And you get direct feedback right away after the colonoscopy. I was like, it's something we can do the colonoscopy, and then we can talk to you right after the procedure and tell you what we found.
So I've had 2 colonoscopies, and I'm saying this as a layperson because I think it's very important. We're asking doctors the questions of what to do, but just as a layperson, this time around, I literally had everything to prep was over the counter, which is fantastic. I got the stool softeners over the counter. I had electrolyte drinks to drink, and life is good, and it's a lovely little cleanse, you know. Last time I did not have a polyp that was found. This time I did, and to your point, immediately after the procedure, the nurse came and talked to me. The doctor came and talked to me. The polyp was benign later, but the bottom line is it was a 10-year description first time around, and now I take it again in 5 years. And the prep, it really isn't that bad. You have diarrhea. Pardon me. I'm just, but it is. I mean, I like being very specific and bold and blunt on this show. You have diarrhea for a good 12 hours. Everything's nice and clean. You go in, you go night-night for 5 minutes, and they do the test, and life is good.
I think the bowel prep is the most difficult part. After
Yeah,
that,
you know, and the prep
that's
isn't
it.
that bad.
Yeah,
it's a little
exactly.
yucky, but really, it's fine.
Yeah,
It's absolutely
100% I
fine.
agree.
And Dr. Elhanafi, I would love for you, since you have this lovely tool in front of us, we've got the colonoscope, correct? So this is what the colonoscopy is. And if you could actually build in a little bit more of what I talked about with the prep, if there's anything I forgot or didn't add, feel free to talk about that. And then I'd like to show the audience what it is that you're actually doing during the colonoscopy.
Absolutely. So to have a good quality colonoscopy, you need a good prep. We need to see. It is all about visualization. How we need to see your lining of your colon very well.
And by the way, I'm not interrupting, but I am interrupting because we have some graphics that we're going to pop up, and it's graphic number 4 shows several normal colons and then we'll show some polyps. So as you're speaking, we're going to go back and forth between these two. So.
Exactly. So before we do the procedure, there is some preparation. We ask our patient to, for the day before the procedure, to eat clear liquid diet to make their stool a little bit in the softer side, and start taking some solution to help them get the stool out and clean out. So it is, everything starts the day before the procedure. If you don't have constipation or any risk factor for poor prep, then once you had the prep, you show up to the endoscopy unit, and the anesthesia doctor will see you to evaluate you before the procedure. Then you go to the endoscopy room, and the anesthesia doctor will give you medication to make you sleepy and comfortable. So this procedure, you will not feel it, you will not remember what happened.
Right.
Everything under sedation.
I kind of want to remember, because that way I can tell about it on the show. I even told them, I said, hey, but yeah, it really is, again, to your point, and as a layperson, people who have not had this before, it's so important.
Exactly. So once our patient is sleepy and comfortable, we use this tube with camera. It is a very flexible tube, which has light source here and a channel for our instrument.
Camera.
So,
sorry, too, where Diego's over in the corner.
so this tube is designed to be very gentle for the colon, and will go very gentle. So we start from the rectum, go up all the way to the cecum or terminal ileum, the right side of the colon. Using this tube, try to go gently and come out gently. So the tube, this fiber optic tube has some wheels here, help us to go right and left, up and down, and we have suction and a channel which you can pass our instrument like snares and forceps or clips, which we're gonna show later. Once we see the polyp, we decide what we need to do. If we need to remove it, or if we see a mass, we need to take biopsy of it. And most of the time, more than 50% of people has normal colon. So once we see the polyp, this is the time we act on it. And Dr. Robles, I think he can show us some of the instrument.
Absolutely. So this is just kind of one of the instruments that we can actually fit through the colonoscope, and it actually helps us remove the polyps. It's more like, you can kind of see, it's actually more like a lasso type of object, kind of you wrap it around the polyp that you'll be able to see in one of the images. We then close it. Our assistants usually are huge helpers in this, as well as the nurses. And once we cut it, we're able to remove the polyp and send it to the pathologist to see what it consists of. So, yeah. And we have various other instruments as well. Sometimes we have to remove very large polyps, in which we have to close the area of the bowel that we just cut. In that case, after we finish removing the polyp, we like to close the area just to prevent any subsequent type of bleeding that can happen. And in this case, again, we also have what we call clips that helps us close. Now, these things, if you've had a colonoscopy and you see the images, they look huge. They're really not that big, actually. They're little tiny things. Those stay there, they fall off, you won't even notice it. So, but again, this little area here, this little thing here, helps us close the bowel exactly where we remove the polyp. So.
Okay. So on that note too, is there a cauterization that occurs when you're moving the polyp? Is there a burning of the tissue? Or describe how once the polyp is off, with the wound, so to speak.
Yeah, absolutely. So depending on the size of the polyp, if it's a smaller type of polyps, we tend to just cut.
Okay.
It bleeds a little bit, but we cut. Now, the bigger polyps, they tend to have a little bit more vessels in them. They tend to have higher risk of bleeding. In those, we use heat cauterize as we cut. Now, sometimes we leave it there, but again, once we cauterize, we stop bleeding. We may still close it with some clips just to prevent any subsequent bleeding in the future, which is pretty much the biggest risk that we run here. Super low risk, but it does exist, so we'd like to prevent any of these type of complications.
So describe what you just said. You like to close it with clips. Is that something that stays then in the colon for a while?
Yeah, no, it stays in the colon for a while. They most of these clips will fall off after a few weeks, and you will not even notice it fell off. There's of course times where you go back in there might be a clip that is still there, but again, these are tiny little clips. They're benign. They're not going to cause any problems or complications, but they're designed to eventually fall off with time.
Okay. And if I have it correct, I know that when you have people in general, and I have several clips in my breast tissue because I've had some biopsies, and they leave a clip there so that when they go back and do another mammogram, there's a clip, and it will be there for the rest of my life. The reason I say this, because people think, well, oh my gosh, the clip's still there. It's perfectly fine, and that's exactly what they're designed
It's
for.
perfectly fine. These clips, they don't interact. You can undergo MRIs if they ever have to, for any other reason. So again, they don't interact. They don't cause problems. You're not going to have issues in the airport. You'll be fine.
You're not going to have issues in the airport. I love that.
That's a more common question than you would think.
Is it really?
And we use it only in certain circumstances when the polyp is big.
Right.
So, but most of the people has small polyps.
Yeah.
So, like more than 20% of normal people, or 20 to 30% has polyps. Very limited number of these polyps are big.
Okay.
So we need to put clips to close the area of resection. So as Dr. Robles said, we have a lot of tools to help us to do the colonoscopy safely.
Right.
And it is evolving, and a lot of new techniques. So it is almost safe modality.
Nice.
So
and it's lovely too, because when we look at this, the program, and again looking at the graphics, 4 is everything's clean, 5 is there are some polyps, number 6 is where polyp removal is happening,
Yes.
and then number 7 is what we don't want to see, and these are cancers. And so for the most part, if you have not had a colonoscopy until you're 60, 70, 80, and boom, you go in there, this could be the problem. But if you're having a colonoscopy at age 45, as we were talking about, they tend to start if there's even anything there.
Absolutely. So actually, I do want to add on that. So we do start screening at age 45. It was decreased from age 50 recently because of the higher incidence rate. So colon cancer is actually going up. Screening works, again, because we remove these precancerous polyps. And at the same time, we can find early cancers where we can treat it and, even be more successful with the treatment. But I do mention that these polyps take years to form. It takes years for them to become cancerous. So there's definitely time for, to catch these things to prevent complications. So it's why we kind of pursue and, tell individuals to make sure you get screening. So,
right. And you have a great graphic, graphic number 8 shows that as the screenings are going up, the cancer rates are going down, precisely to your point.
Absolutely. So, I do want to mention a statistic. So colon cancer is the second most common cause of cancer death in men and women combined, but it can go down and we can prevent it with colonoscopy as the trends have shown here in this graph. It's actually going down. You screen more, rates go down. So it helps.
And this is great to talk about it. And I know sometimes it's uncomfortable and you squibble in your chair a little bit and you talk about diarrhea during prep, but I'll tell you what, it's a lifesaver. And I think it's great that we're here talking about it.
And I want to add just a small thing, what Dr. Guzman said and Dr. Robles. Screening has impact and had decreased the incidence of colon cancer. So what I say, colonoscopy is perfect, is the gold standard, but whatever available, use it. So the best test is the test available for you can do. So any screening test is good, but just do one of them and we'll go from there. If it is positive, you will need colonoscopy, but if it is negative, you get assured. So anything is better than nothing.
Right.
That's true.
Agreed. On the note of someone not having done anything yet, and say they're 65 years old, have not had a colonoscopy, what are some of the signs and symptoms of colorectal cancer? What is it that people can look out for that maybe have not had a screening yet, but they should think, okay, well, maybe it's time?
Good question. So I actually want to first start off. So just to be aware, early onset, when it's early on, there's no symptoms.
Okay.
There's no symptoms involved. Again, this is why I emphasize the importance of screening. But now what we call the red flag alarm type of symptoms, when we start seeing blood in the stool in the toilet, change in stool calibers, change in bowel habits, abdominal pains, new onset constipation, used to having daily bowel movements. Now you're going to the bathroom every 2 to 3 days. So these are all signs and symptoms that should be discussed with your provider, your primary care provider, to pursue further action and find what's causing these things.
Right. And now let's talk about treatment. So treatment and management. So we were talking a bit about prevention. Diagnosis is what's happening here. Now we have someone who had some polyps removed. They are cancerous. And now what? And so I know that's different for every person. I'm in full respect of that, depending how many, the size, etc. Who wants to start that? And then we'll go from there.
So it depends. Anything we remove from the body we send for pathology. So small polyps, usually it is precancers. There is some benign polyps, is even not precancer. Just it will be like normal tissue. But there is some precancerous polyp. It depends on the size and the morphology and the type under pathology. So if it is precancer, we recommend repeat surveillance in shorter period than 10 years. So some people will come at 7 years, some come at 5, some come at 3, some come at 1 or shorter. So it depends on the pathology. So this is the polyps, which are different from cancer.
Okay.
So this is most of the people, like more than 30 to 50% of people may have this benign precancerous polyp.
Okay. So that almost sounds, for me, oxymoronic, because it's benign, precancerous. So benign to me sounds like there's no cancer at all,
Yeah.
but precancerous is that eventually if a polyp stays in there long enough, it will become
Exactly.
cancerous.
Yeah.
Right. So I just wanted to clear up why that wording
Definitely,
is the way it is.
you made it correct. So I
Okay.
think benign is not precancerous. Precancerous is before to become cancer if left there for a longer period. So, but they are not cancer yet. That's why we are doing screening. Look for this type of polyps, which you can, by removing these polyps, will prevent colon cancer.
Okay.
The best treatment for any disease is prevention. So we are trying to prevent cancer.
Right.
So this is why we are here today.
Okay. So now we're looking at someone, polyps, like you said, cancer, two different things. Now we're looking at colon cancer. What are options there? So we're looking at surgery, we're looking at
Yes.
et cetera, et cetera, et cetera. And again, everyone's different, but just throw out some case
Yeah, no,
studies.
absolutely. So a lot of it also depends on the location, but just in general terms, the first thing we want to figure out is how much does it extend? Is it mostly just in the colon? Is it kind of maybe spread just outside the colon, or has it spread diffusely throughout the body? Now, knowing these things will change the management course. So early stage cancers, meaning it's just kind of mostly localized in the colon, the treatment is actually surgical resection. So surgical resection is considered curative for these type of cancers. Again, these are the early cancers. So again, why screening is important, because we can capture these cancers at that stage. Now, when it's spread a little bit more than that, in addition to surgical interventions that may be required, this is where our colleagues come into play. Again, this is a multidisciplinary type of approach with social workers, oncologists, surgeons. It may involve chemotherapy, immunotherapy. There's a lot of new medications coming into the field of how to manage, and there a lot of great success with these medications. It's going to vary quite a bit from one person to person, depending on genetic testing that they do on the cancer and things like that. So.
Okay, so that you opened up a whole can of worms there. So is there an automatic genetic testing on a malignant polyp cancer, et cetera? Is that an automatic thing? Or is that something that people may or may not choose?
No,
to do
absolutely. So
genetic testing?
anytime a cancer is diagnosed, the pathologist immediately run a genetic test on it. So,
Okay.
And this facilitates the management for the oncologist or
Describe
cancer
that
doctor.
a little bit. So how is that done? And if you don't know exactly, you said, it's multidisciplinary.
No,
It's like, I know that's not your specialty, but it just makes me curious.
Our multidisciplinary
Okay.
experts on the other side. So,
Okay.
who are experts on these type of things. So again, that's why it involves, everybody plays a role
Right.
in here in the management as well.
See, I feel like we don't hear enough of that, at least right now. We hear a lot about in female cancers, breast cancers, gynecological cancers. We know it exists with colon cancers, but I feel like we don't hear about the genetic testing a lot with colon cancer. So the next time we do this, I'd love to know a little bit more and get some more information out
I
there.
think it is as you said, and Dr. Robles said, they do it routinely for any cancer, and it helps to personalize the treatment. And the oncology or cancer doctor can choose which type of treatment he can give, and also it can help to us to see if the family members of this person need a screening or immediate action as well. So it guides us from what's the background of this cancer. So it is evolving, and in most of the tertiary care centers and academic centers, they do this as a standard of care.
I am taking notes as you're speaking. Dr. Robles, I'd love for you to talk a little bit more about the surgical resectioning. And again, you were talking about a certain section of the colon, depending how much is affected. How is that resectioning done? And then when and if do people need a colostomy bag?
Yeah.
Sometimes not, sometimes yes. And I just think people are curious as to how that whole process works.
Yeah, absolutely. So again, we run with our based off a lot of decisions. Our colorectal cancer surgeons make these decisions. But yeah, so the colon, the cancer is more on your right side of the bowel. You know, it may involve removing the whole side of that right side versus on the left side. Now, the main intention here is to be able to hopefully connect the bowel together and avoid the creation of a colostomy. Okay. So that's the main intention. We want to prevent that. But in some cases, whether maybe it was it's a type of obstruction in which there was not enough time to prepare the bowel for the surgery. And these are the cases in which an individual may end up with a colostomy. Now, these colostomies, again, with the intention is at first that it may only be a temporary measure, but unfortunately, a lot of times it becomes a permanent stay. Yeah.
And so when you say a permanent stay, and I'm thinking too, once you have this surgery and it's a resectioning, and this person then every 2, 3, 4 years gets another colonoscopy?
Oh, yes.
Would that be the retesting? And then from there, is there anything different in the way they're being tested?
So absolutely. So after surgery, after removal of the tumor, of the cancer that was there actually your screening changes. Remember, we were mentioning that your screening varies depending on how many polyps you have.
Right.
Once you're diagnosed with colon cancer, you kind of put in a different screening type of program where we first do another screening colonoscopy 1 year after your treatment. After that, we do it in 3 years, and thereafter you do it every 5 years. As long as you have normal colonoscopies, we repeat a little bit more frequent. Even though we removed it, the fact that you developed the cancer in the first place puts you at risk. There might be a genetic component that predisposes you to colorectal cancer, so we want to prevent it and catch it early. So you do get screened more often.
Okay. Dr. Guzman, I just need to bring you back in the loop. So let's talk about someone who has had colon cancer, has had a resectioning of the colon, who now is, 1 year, 3 year, 5 year beyond. Is there something that this patient is doing? Treatment's the wrong word, but maintenance wise going forward, if they've already had cancer, it's already been treated, they're in remission. And let's say, again, to me, 65 is super young, but it's retirement age. So I feel like, okay, this is the good age. Is there management that they're going through going forward through the rest of their lives other than just going to their colonoscopy?
So if they're able to, if the surgery goes well and then they receive chemotherapy and they're now in remission, they live completely normal lives. Now, if you're asking as far as what can they do to prevent it from coming back, it goes back to that whole there being modifiable risk factors and non-modifiable risk factors. So it's the routine stuff that is good overall. Like obesity is something that we can work on. Something such as a sedentary lifestyle. If you exercise, that always plays a good part into reducing your risk. Smoking. Quitting smoking is going to help you prevent becoming the risk of colon cancer. So those are things that they can do as individuals to decrease their likelihood of redeveloping it or developing more colon polyps. But mainly it's for colon cancer. Okay. And so these are the modifiable things that they are able to do in their just routine lifestyle to be able to try and prevent this from happening again.
Gotcha. So let's talk now. Yes, go ahead.
And one more thing.
Yes, please.
And very important as well, the compliance with the screening. As in you have to be there if it's okay at 1 year, at 3 years, and then every 5 years, because cancers can come back. And the idea is that if we're able to, you had everything well, and if we detect a growth early, we can treat it early.
So we were talking about risk factors. I don't know if we actually did talk about risk factors, but the highest risk factor for colon cancer is having it once before. On that note, what are other risk factors? You talked about obesity in general. Are there some that we haven't discussed yet that we should bring up? Risk factors?
Yeah, I think one of the important risk factor, if you have family history of colon cancer.
Okay.
If one of your first degree relative has colon cancer, so you are at risk. So you need to be screened earlier and more frequent.
Excellent.
So if you have like one sibling or one of your immediate relative, you have to ask your primary physician how soon I need to be screened and how frequent. We'll let you know when you come for a screening. We'll let you know how frequent you need to be screened, because genetics is one of the important risk factor for colon cancer.
Okay. Super important there. Risk factor, I'm not sure if that's what we should call it, but I do want to talk about IBS, which is irritable bowel syndrome, because I feel like a lot of people have this issue. And a lot of people think, oh my gosh, is this going to lead to something worse? Dr. Robles, you said, and started smiling and nodding.
Yeah.
So guess who gets that question?
No, that's fine. No.
Great. Let's talk about IBS.
So irritable bowel syndrome, to not be confused with inflammatory bowel disease, because when you abbreviate it as IBS,
Yes, yes. Please do that. Yes.
So in first discussion, irritable bowel syndrome, we consider this, it's a very bothersome syndrome that's out there. It's a common syndrome. I 100% agree with you. But at the same time, it does not really carry any risk of developing any sort of cancers.
Okay.
It's something that we want to manage symptoms-wise, either with medications, through dietary changes, but again, does not increase the risk of developing any sort of cancer. Again, but at the same time, we want to improve the quality of life. So this is something that we also deal with as gastroenterologists. Now, the other condition, the IBD, which is inflammatory bowel disease, to not be confused with IBS, this is what we call either Crohn's disease or ulcerative colitis. Now, these conditions does increase the risk for colorectal cancer.
Okay.
Individuals with these conditions actually do undergo screening more frequently and at a younger age. We usually start screening these individuals either 8 years after they were diagnosed, and we screen every 1 to 2 years.
Now, I'm going to jump in just because I know people are asking, how are you diagnosed with IBD, with inflammatory bowel disease? Like, how is that diagnosed? Meaning, what are the symptoms? For someone to have to go in and go, something's wrong, how am I diagnosed?
Absolutely. So again, a lot of these symptoms start with rectal bleeding and diarrhea.
Okay.
A lot of worrisome symptoms that we mentioned earlier. Hey, you really should be kind of talking to your doctor about these things. And these right away draws red flags. Again, we're always thinking colon cancer, but at the same time, we're also thinking there are other conditions like inflammatory bowel disease. Now, at this time, we do a colonoscopy, which is very helpful in helping us remove polyps, but at the same time, being able to diagnose other conditions. In these cases, we see inflammation in the colon. We are able to take biopsies. We do some additional lab tests, some additional stool studies that can help us verify and confirm the diagnosis of IBD, inflammatory bowel disease.
Okay. And on that note, too, Dr. Guzman, you get one now, too. How does one be diagnosed with IBS? Even though it's relatively benign, it's a bothersome type thing. It's like, it's always an issue. So how is that?
It is. And then one thing I wanted to expand as far as for IBD, it's an autoimmune disease. Essentially, your own body is attacking the colon. And that's what causes the inflammation. And that's why the constant inflammation can lead to cancer. So that's why it's important to get patients with IBD under control as far as getting them on therapy that needs to be done. And that's why once there's a lot of inflammation and ulceration, that's when they start having the bleeding or they start having all this diarrhea. Now, IBS is something that is a diagnosis of exclusion.
Diagnosis of exclusion.
As far as we have certain criteria that we use for patients with IBD, but typically with IBS. But the majority of the time it is when we have ruled out things that are of concern, such that would be more, I guess, critical to their care as far as like the inflammation with IBD. So usually we see, make sure that it's not an infectious etiology that they've been having. Like if they, let's say, for example, if they have IBS with diarrhea, okay, because there's two types. There's IBS with diarrhea and IBS with constipation.
Oh, so you have one or the other.
Or a mix. Or
okay.
A mix. But if you have somebody that comes in with IBS-D, which is with diarrhea, we try and make sure that it's not an infection from, you check your stool studies, make sure you don't have some type of infection. We look through your medication. We sometimes do a colonoscopy to make sure that it's not something else that's going on in the colon, such as microscopic colitis. Once we've ruled out those things and any organic causes to the diarrhea, then that's when we fall into the area of IBS.
Okay.
And at that point, it's a lot of treating the symptoms. where we essentially try and control the diarrhea. And it is, I wish Dr. McCallum would be here because this is one of those things that
he loves talking about this.
Yes, it's the gut-brain.
Right. The gut brain.
Gut brain.
Yeah.
So this in itself is where that pathology falls under.
Okay.
And same thing for the constipation type. I don't know if.
And in the old days, is IBS now what? And you guys are I'm 57 years old. I'm the old lady here. But nervous stomach. Do you remember when your grandparents? Oh, he's got a nervous stomach. Oh, she has a nervous stomach. Is IBS what we used to call in the old days nervous stomach?
Yeah, I would definitely agree with the nervous stomach.
Okay.
It is a condition that's more common in individuals who may have anxiety, things like that. And a lot of the medications we use for IBS are actually anxiolytic type of medications to help with that gut-brain interaction.
Okay.
The same chemicals that are released in the brain are released in the gut and can cause these symptoms. So we can control those symptoms through these types of similar medications. So.
That always made sense, and I think Dr. McCallum is one that brought that up one time. We're still have a little bit of time, but I do want to bring up Crohn's disease because I feel like we hear about it a lot. We hear about it in advertisings, on television, this and that and the other. Who wants that one?
So Crohn's disease is part of IBD.
Okay.
So it is type of IBD. So the main
so we're talking inflammation. There's a lot of inflammation.
Yeah. So there's ulcerative colitis and Crohn's disease. Is
Did you say that again? Ulcerative colitis?
Ulcerative colitis.
Okay.
And the other type is Crohn's disease.
Oh, then let's talk about the differentiation of the two. Okay.
So both of them called IBD, inflammatory bowel disease, as Dr. Guzman and Dr. Robles said. So this is the immune system get confused and start attacking the lining and layers of the colon. So there is some trigger happen and make the immune system attack the mucosa of the colon and cause chronic inflammation. So this is what's called IBD. Okay. Crohn's is relatively different from ulcerative colitis. Ulcerative colitis is most of the time limited to the colon and it doesn't involve the small intestine. But Crohn's can involve all the digestive tract from mouth to anus and can cause.
So say that again. Crohn's disease can affect from the mouth to the anus. So the entire digestive tract.
The entire digestive tract.
Okay.
The small intestine and the colon are the most common sites, but can become anywhere.
Okay.
And the ulcerative colitis is limited to the colon.
To the colon. So when you say literally from the mouth to the anus, and let's travel right now from the mouth to the esophagus into the belly, what is it that we're looking for? Again, the mucosa lining, there's issues there.
It is not common to be in the esophagus and stomach, but it can be there.
Okay.
It's rare. So most of the time it is a large intestine, the colon, and small intestine.
Okay.
You see some ulceration, inflammation of the mucosa, and it can appear in imaging or in colonoscopy.
So here's the $1 million question. How is that treated? I'd imagine diagnosis is one thing, but if you have Crohn's disease and it's the entire tract, it's not like it's easy just to say, okay, we're going to focus here. Dr. Robles, you again, when you nod, you get the answer. You get the question. So he's like,
I'm
okay.
I'm
so
with that.
treatment of Crohn's disease.
So treatment of Crohn's disease and ulcerative colitis. A lot of medications are used in both conditions, okay?
Okay.
We are talking biologic therapies. These are medications that are designed to stop the inflammatory process at where it originates, which is your own body creating this inflammation. However, medications do vary quite a bit. There are certain medications that we only use for ulcerative colitis that we do not use for Crohn's disease. Now, the fact that ulcerative colitis it's just the large intestine, the colon. The medications can involve oral medications, even enemas, meaning going in with medications through the anus into the rectum to squeeze an anti-inflammatory medication in there. While Crohn's disease, again, it just involves more the small intestine, the large intestine. Actually, it can even cause inflammation in the joints, inflammation in the skin, can cause rashes, can cause inflammation in the eyes. So Crohn's disease just is more systemic.
Okay.
Medications for Crohn's disease tends to be a little bit more of the biologic medications. These are medications that we give either through an IV or injected medications. Very few oral medications for Crohn's disease. Again, as time passes, they're definitely developing new medications that can eventually, hopefully one day, just involve the normal medication. But in the current time frame, we're talking a lot of injected type of medications.
So question here too, where does Crohn's disease come from? Like how does one get Crohn's disease? Is it something that you just have, that you got from grandma and grandpa somewhere along the way? How does one know if they're at risk?
So there's definitely familial component, but it's not that large of a play here. If a family member, the first degree family member, has an inflammatory bowel disease, whether it's Crohn's disease or ulcerative colitis, there's about an 8% chance that your son, daughter can develop the same condition. At the same time, there's a lot of components that we still don't know about, or what's originating this. Some people assume it could be an infection that individuals got early on that just caused your body to go into overdrive, and during that process of eliminating that bacteria, it started detecting your bowel as foreign, so then it started attacking it. Again, we're still learning. There's definitely theories. We're not 100% sure, but again, it's an ongoing process to learn more, so to be able to manage it better.
I talk often on this program that next year, if we have this exact same program, there's going to be new stuff that you bring to the table. And that's what I love doing this. We do a colonoscopy type of a show every year, and every year there's something new. We're at about a 14-minute mark of the show ending, and I know it goes by super, super fast. On that note, we covered a lot, but I know there's a lot on the table too that we'd like to either do a deeper dive into or something that we haven't yet covered. And Dr. Elhanafi, because you are the true veteran, and the one that everybody bows to on this table, you get to go first. Is there something that we haven't talked about yet, or something that you really want to cover a little bit deeper?
No, I think we covered most of the aspects of the colon cancer, but I would like to let our community know that there is resources there for you. If you don't have resources or insurance, or your insurance doesn't cover screening, there is always resources. Ask for it. And there is a program we have in Texas Tech, UMC as well, which can cover and help you to get screening for colon cancer. The program is sponsored, and you will pay nothing, but you have to qualify for it. So you can contact Texas Tech. Dr. Moloko is the principal investigator of this program to support.
Dr. who? I'm sorry?
Dr. Moloko, Jennifer Moloko.
Okay.
Family
Can you
medicine.
spell that for us?
It's
not
MOLLOKO. So you
Just
can ask for the program for colon cancer.
We'll just ask for program for free screening.
Yeah,
It's called
exactly.
Success.
So
It's called the Success Program.
The program is called
Perfect.
Success. So it is available for people who are underinsured or non-insured, and with certain criteria. You may get any type of screening there, and they will help you. They are very nice people. So we are happy to let you know about this program.
No, I'm super glad you said that. That's something that usually the doctors don't want to talk about insurance because it goes into a whole nother rabbit hole. But I'm super happy that when that is brought up, because in and of itself, colonoscopies are intimidating, which is why we're talking about it. But if that lessons just one less, I have to pay for it. How much is it going to cost? If there's a free program available, that's great. And again, it's called the Success Program at Texas Tech, UMC, and Dr. Google. You can just do the search engine on that and find it. Just the Success Program in El Paso, Texas Tech, and UMC. So glad you brought that up. Dr. Robles, how about you? Anything that...
No, I just want to reemphasize the importance of screening, like Dr. Elhanafi, Dr. Guzman have been saying. So, screening is important. Screening helps us prevent colon cancer. It helps us capture colon cancer. When we talk 5-year survival for early stage colon cancer, we're talking above 90% if it's caught early. And again, when it's early, you're not having symptoms. We're going to figure this out because you did a screening colonoscopy, and survival rate is above 90%. Now, if you wait, we're starting having symptoms. Now, it's very late stage. Survival goes down to about 15%, 5-year survival. So there's definitely a lot of benefit in screening, not just for yourself, but for family members who, want to have you around for many years to come. So just consider that into the equation.
Yeah, if there's people love you, it's good to stick
Yeah.
around. Dr. Guzman, anything that you want to cover? And I do want to touch base on diabetes before we end, because we do have a little bit of time, and I feel like there is an issue with diabetes and this whole situation too. But Dr. Guzman, something that we haven't touched base on yet that you'd like to or go deeper into?
No, I think just to emphasize everything that we've been talking about, I think we all grew up in, we talk from experience where we grew up in communities here in El Paso, and it is not to be fearful of this. A lot of the times people are fearful of saying, what if we go in and they find something?
Well, that's a good thing, because then you can make it go away.
Exactly.
Yeah.
It's about coming in and trying to get things diagnosed early, or being able to prevent things. Like Dr. Elhanafi said, prevention is the best treatment. And it just for the community, be reassured that we're here to take care of them, and we're here to help them, and that this is something that is going to be beneficial for them in the long run.
Exactly. And diet, and I think about diet too, because I know that with in El Paso, you two grew up here. We have a lot of diabetes issues here in El Paso. Does that factor in at all with colon cancer? And if so, how?
Yeah, so diabetes is actually, when Dr. Guzman was talking about the modifiable risk factors. So diabetes can actually fall under both modifiable and non-modifiable,
Okay.
depending on what kind of diabetes. But diabetes is a known risk factor for colon cancer. Again, diabetes is usually brought on through dietary changes. So again,
Right.
this all goes back to your diet. There's definitely healthy diet habits, including eating high fiber foods, your fruits, your vegetables, keeping it low on the red meats, and things, and fatty foods. All these are risk factors, and again, some are protective, like the high fiber type of diet. Now, this eventually protects you diabetes, and again, some evidence that it can hopefully prevent colon cancer. So.
Excellent. I'm glad we brought that up too. I do want to talk very quickly, because we were talking about Crohn's disease. And again, in my head, prior to coming to this program, I wasn't focused on anything but the colon. But if we're looking at esophageal questions too, because just Barrett's esophagus, for example, or just heartburn, or issues that just affect the tract in general, where does that call into? For example, if you have GERD, and if you have heartburn a lot, does any of this have to do with colon cancer later, because it is part of the entire system, or does it not at all?
No, it should. So if you feel something abnormal, get yourself checked.
Okay.
So usually reflux or Barrett's has no relation to colon cancer. But if you see something abnormal, like you have abdominal pain that not gone away, or you feel like you are losing weight, or you have some blood in your stool, this is something is not normal. So blood in your stool is not normal. Can be coming from your stomach, can be coming from your esophagus, can be coming from your colon. So you need to see a specialist. And in El Paso, we have many good specialists. In Texas Tech, UMC, or community private people, they all great. They are willing to help the community, and it is not only one place or one person. It is many people available for you. If you have any problem, just get it checked.
Just
And
get it checked. I'll throw a case study out there, which is my own. I was 48 years old, and my dentist said, well, Catherine, you've got a growth on your tonsil. And I literally had a polyp on my tonsil. And I thought, I've never in my life heard that before. So I had a partial tonsillectomy, and the doctor said, you're only 48. This is before the screening guidelines were at 45. It's when the screening guidelines were 50. And so at that point, I thought, oh, I'll get a colonoscopy at 48, which was good. There was nothing there, but now I just do it every 5 years, because even though that's not in my colon, I get it, it's on my tonsil. But you said earlier, it is literally from the mouth to the anus, so everything in between. If there's something a little bit odd and funky, if your insurance covered, get it checked out. And if not, again, I'm going to keep talking about this, the Success Program at Texas Tech and UMC, again, that is something that you can do screening for free.
Absolutely.
Okay. We actually have a little bit of time, and so I am going to ask a couple of questions that we have from old shows. There are, I don't want to focus too much on GERD, but tell me about anti-high pylori treatment. What is that exactly? And I know it's not colon related, but it is digestive tract related.
No,
and it's
it's,
something completely different, but I have it in my notes from 4 different places from the show we did
I
last
think
time.
if we talk maybe about diverticulosis, is something colon also people ask about.
Okay.
Yeah.
Okay,
Yeah.
let's do that then.
Yeah.
Yeah. So H. pylori is a bacteria in the stomach.
Okay.
That's actually the main cause of stomach cancer.
Oh,
in the
gee, so
entire
completely
world.
different. Okay.
A complete separate entity.
yeah.
And we eliminate H. pylori, we detect it, and we can decrease the risk of developing stomach cancer. So,
Okay.
Yeah.
Well, that's a little bit too easy of an answer. That doesn't give me enough time. But what I do want to say to the people that are watching right now, there is this program, and both PBS El Paso and the El Paso County Medical Society, as well as YouTube, now has just series of programs for the El Paso physician. So if you're watching this show and you didn't catch it all, you can go back to, again, YouTube El Paso, or not YouTube El Paso, YouTube, and then go to the El Paso physician. You can also go to pbselpaso.org and then find the El Paso physician and then El Paso County Medical Society and find the logo there, because what they do have now, and again, back in the old days, you had to get the little tape or the DVD, but you can go back and find colon cancer, you can go colorectal cancer, you can go to any issue that we've talked about, and they have things log back and archived for years. So you can kind of see the difference between this show, last year's show, and the shows that we do and have come up as well. So I want to say thank you so much for sticking around with us. And you have been watching this program on colon cancer prevention, diagnosis, and management. Again, we've got shows that are coming up every single month. And if there's ever a question that you have that you want to throw our way, you're more than welcome to call the El Paso County Medical Society, get that question to them, and we can answer it either then through email, or we can go ahead and answer it on the following show. So thank you so much for watching. I'm Catherine Berg, and this has been the El Paso Physician. Hi, I'm Catherine Berg, the host and the moderator for the El Paso Physician. The El Paso County Medical Society has sponsored this show now for over 26 years. We've had a lot of topics throughout those years. And kudos to the doctors on the El Paso County Medical Society, because this is the longest running local medical show in the United States, in fact, around the world. This show that is produced in El Paso gets picked up by PBS stations in other cities, which is great. If you've ever had a question on one of the topics that we presented, you are welcome to email the El Paso County Medical Society and its doctors, and we will make sure to get that question answered and back to you. The place to email is epmedsoc.com. That stands for El Paso Medical Society. Again, epmedsoc.com. You can email your questions there, and one of the doctors from the El Paso County Medical Society will get back to you. Through the years, 26 years, we have so many episodes that you can go back and watch. Now that streaming is in place, there are 3 places that you can do that. pbselpaso.org is one. You would have to go there and look for the logo, the El Paso Physician, and we have, again, many shows that we've aired through the years. Also, the El Paso County Medical Society.com. And then there's always the good old-fashioned YouTube. Just in the search engine, YouTube, and then type in the El Paso Physician, and you will see all the topics that are there throughout the years. If you're looking for a specific topic, just enter that into the search engine, and you'll be able to find us. Thanks again for tuning into the El Paso Physician.